Welcome everyone. I'm Cinda Rushton. I am co-chair of the Johns Hopkins Hospital Ethics Service and faculty member in the Berman Institute and the School of Nursing. And I'm really delighted to welcome you today to our Ethics for Lunch. And this is a topic that for those of us who have cared for children and their families is a really difficult topic that we're going to take on today. Should children be told that they're sick or dying when their parents refuse to do so? And we have an incredible panel today. And it's actually a new collaboration for us with our colleagues at All Children's in Florida. So we have Christina Berger, who is the co-chair of the ethics service there and also involved in palliative care. We have Lexi DeLone, who is a child life specialist here at the Johns Hopkins Children's Center. We have Lori Rome, who is an extraordinary pediatric oncology nurse. Matt Norvell, who is a pediatric chaplain. April Sharp, who is a pediatric neurologist. And Simone Thompson, who is a social worker. And so what we're going to be doing today is presenting a case that is derived from composite experience to illustrate the issue that we want to take up today. And we invite you to share your comments and your thoughts in the chat box. And when we finish hearing from each of our panelists, to invite you to engage in some dialogue about the ethical challenges that this case represents. So Christina, do you want to start us off by sharing the case?
I sure will, and thank you very much, Cinda, for allowing us to collaborate with you from All Children's down here in Florida. I'm thrilled that we're able to do this. So I'm going to present our case today. It is KM is an 11-year-old girl with a history of pre-B-cell acute lymphoblastic leukemia, or ALL, with multiple relapses. In the past, she has been treated with chemo and immunotherapy, both of which were associated with significant side effects. After her third relapse, she underwent a bone marrow transplant, requiring a prolonged hospitalization for treatment of acute graft versus host disease. At hospital discharge, her leukemia was in remission, but she had deconditioning from the prolonged hospitalization and persistent nausea that limited her oral intake and activity level. At her 6-month follow-up, she remained in remission and was starting to get some of her strength and appetite back, although she was not back to her pre-transplant baseline. By 8 months post-BMT, she was starting to get fatigued more easily, had increasing nausea, and developed a fever at home, prompting presentation to the emergency center or department. In the ED, she appeared pale and weak and had lost 4 pounds. Bloodwork showed pancytopenia and peripheral blasts consistent with recurrence of her leukemia. Her parents were devastated and requested the team not tell the patient until the treatment course had been decided. Upon discussion with Oncology, she was not a candidate for ongoing protocols due to end organ damage. Parents then made the difficult decision to focus on palliative care. Hospice was offered, but the parents declined because they did not want her to know that her cancer had returned and that she was going to die. When the oncology team encouraged her parents to discuss the relapse and palliative care plan with her in an age-appropriate manner, they still refused, stating they worried that she would lose her faith in God and God's plan. They wanted her to enjoy the time she had left with her family and friends without feeling sad or anxious about the end of life. And I think at this point, we have a good understanding of where they are. Cinda, would you like me just to disclose the questions we'd like to have everyone think about? Okay, so we have 4 questions we'd like for you to consider. What are the clinical and ethical issues that can arise when medical information is withheld from children at the request of their parents or guardians? What responsibilities does the medical team have to pediatric patients and to their parents or guardians? How does a family's culture and faith affect the decision-making about how and when to disclose information to a child, especially if it is against the wishes of the parents or guardians. What resources can be provided to help families through difficult conversations about severe illness and end of life? And I think just as a quick introduction, certainly there is a lot of staff concern around situations such as this. And really the questions do kind of beg us to think, at what point do we not follow the parents' wishes, or do we always follow the parents' wishes? And does that mean that staff perhaps may think that we're asking them to lie to a family or to a child? And so we don't ever want folks to compromise the integrity of their values. We want our staff to feel good about the care that they're providing. And so where do we move forward with this type of situation? And I'll hand it back over to Cindy.
So I think Christina has done a good job of laying out what the ethical concerns are in a case like this. And I wanted to invite Lori to reflect as a pediatric oncology nurse who I'm sure has been in this situation more than once. How do you approach these kinds of situations, and what are the ethical concerns that it raises for you?
So I can tell you all that having been a pediatric oncology nurse for over 18 years now, just hearing the case study makes me feel a little bit uneasy, as these things always do. I was talking with my mom about this discussion today, and she reminded me that in the mid-1970s, when her mother was dying of pancreatic cancer, that no one said the word cancer to her, and that no one explicitly told her that she was dying, as she was miserable, lying in a bed, actively dying. And so our cultural norms change, and hearing this story now just sounds like we are denying the family a chance to communicate. But there are a lot of communities in which there are cultural concerns, and Matt's going to talk about the religious concerns or religious framework that this family is dealing with. But I think that for the most part, in our work environment, when these situations come up, when parents don't want to talk with their child about their impending death or even their diagnosis, they fall under a few categories. And all of these reasons are so human and so natural in terms of dealing with death and dying. I think that the parents' stance of wanting to protect the child is probably the most common seed of a reason for not wanting to communicate with them. Not knowing how to talk with the child in a developmentally appropriate manner that wouldn't be scary for the child. Being scared or in very appropriate denial themselves. Feeling that hope and open communication are mutually exclusive, and having some fear. This happens very often, that parents feel that somehow communicating honestly with their child would make the child somehow lose their will to live, and that they would be denied precious time with their child. But if we go back to my grandmother, even though no one told her, she knew that she was dying. And I think that a lot of our patients do too. I can't tell you how many children, tiny children over the years have said things, spontaneously started talking about leaving, or talking about going to see a dead grandparent, or drawing angels. Children and young adults, they know things, and they're curious, and they are eager for our honesty and for information. And so sometimes near death, there's the risk that the child's selfhood can get lost. So I think about I remember a 5-year-old very early in my career, that the instant that we were alone in a room together, she grabbed the edge of my scrubs and said, "How sick am I? Like, tell me what is going on here." And I can think of a 12-year-old who grabbed my hand equally urgently to ask me who was going to take care of his mom when he was gone. So very often children have an urge to know. And I think that as caregivers, it's very easy to feel morally distressed bearing witness to these situations. So as a bedside nurse, I feel that it is very strongly my moral obligation to be honest with my patients, and to honor the authority and the autonomy of the parents and the child. And so there's the really complicated edge. How do I stand in my integrity and have the room where everyone else involved can stand in theirs? So when I hear the story of KM, I feel that the parent is trying to protect the child, and the child might be trying to protect the parent, and they're sitting in this room with a child dying, feeling more alone and isolated than they probably ever have, as they're going through the most difficult things that they've ever gone through. So as a frontline nurse, I try to find a way to bridge the gap, try to find a way to help the family communicate in a way that's in alignment with the parent's definition of what it is to be a good parent, and the child's definition of what it is to be a good child. I think that very often we see children who don't want to talk about their dying because they don't want to disappoint anyone. They don't want anyone to feel like they are giving up, and they often feel like they are failures. So they keep this secret of their failure to themselves, which is certainly a very lonely place to be. And I think that our language around battle, as children are fighting chronic disease, sometimes does them a tremendous disservice. Another source of moral distress for us as caregivers is that we've seen what we perceive to be a good death, and we hope for it for everyone who dies under our care. And there's that feeling that if we don't do something, if we don't help to bridge the gap for this family, that there will be like epic FOMO, that there will be this epic fear of missing out. We have this fear of missing out, that somehow the time that the family has will not be defined as sacred time if communication doesn't happen more honestly and openly. But all of that said, I think that one of the biggest ethical things is that this is not my story. It's KM's family's story. And her parents are going to have to live with how things go in a much more immediate and intimate and long-lasting way than I do. And so part of my ethical duty is to try to provide an environment that's open for the family to communicate while being very much aware of my personal bias towards honesty and openness, because my push towards directness could actually do harm if it's received in a way that's disrespectful. And then there are times that I've seen where families haven't talked honestly. And my concern then is just that the room is full of love. And if a parent is holding a child's hand and comforting their child and being there and being present, and everyone is feeling love, maybe the words aren't so important. And one last thing that I take very seriously is that I have signed up to be a pediatric oncology work. You know, my specialty is not dermatology, or, you know, I've signed up to be in a place where this happens. And so I have a moral obligation to be competent in this, that if a patient or a parent opens the window to talk about end of life issues, that even if I can't get there myself with them, that I have an obligation to be able to keep that window open for open conversation and dialogue.
Lori, thank you for framing this so beautifully for all of us. I think one of the questions that I'm going to ask April to reflect on is, children have different degrees of ability to understand information, and how do we involve them in ways that are meaningful based on their own development? So April, what are your thoughts on that?
So as a pediatric neurologist, often we are faced with situations of new severe injury, often long-term disability, then death where the patient knows that they are dying, but sometimes that also happens. Am I doing okay? Am I lagging?
You are lagging a bit.
I tried to turn on my hotspot and it didn't work.
If you want to turn off your video, it's fine too, if that helps.
Okay. It probably will. Thanks. So very often we're talking with families about how to tell their children about a severe injury or long-term disability or long-term functional loss that they once had. And so we know that kids understand different things depending on their age and their developmental level. And part of development is about their underlying diagnoses, whether they were previously healthy or have other things going on. And so the information that we tell them and how we tell them is going to differ based on what they can understand. And we want to be mindful of how they understand it so that will help their process of understanding and grieving and acceptance. A couple of recent cases that were similar highlight this for me. We had a couple of kids with a similar cervical spine injury, so neck injury, where they're paralyzed from the neck down. One was a preschooler and one was a teenager. And so very different understanding of what is important to them, what things that they want to be able to do, and what they expect for the future. And so kind of we walked the family through how to let them know that information and what they would want to know. So a preschooler, for instance, cares about playing with toys and running outside and playing with friends. An hour and 10 years is about as the same length of time for a preschooler. It might as well be the rest of their life. Whereas a teenager has some idea of what they wanted to do in the future, has friends, has things that they enjoy, and a sense of their sense of self. And now that self has been changed or maybe coming to an end. Children begin to develop a sense of death and dying around 4 or 5 years old. So younger than that, it's difficult to talk about that with them. But around that time, they have some experience with death and are developing an idea of what that is. A teenager has much more experience and has, again, that sense of self, of future, and that can conceptualize what it means for him or her to die. And so in approaching these conversations with families, it's important to talk about, what the child enjoys, what the child understands, what experience they've had so far. Have they lost family members? And have they then had to reflect on or talk about death or disability? And if they haven't, then that changes the conversation. So really getting a good understanding of the child and the family and what's important to them is just really valuable in having these conversations. And then the last thing is helping the family see things from their child's perspective. And I think Lexi is going to talk about this more, but that's one of the things that we help families do when they think that they're either protecting their child or their goal is to do what's best for them. But it can be hard to remember what it's like to be 11 years old and to think like an 11-year-old when you are now used to thinking of like a parent who's supposed to take care of their child. So trying to show them things, point out things that they do, and language that the child uses, and really being a cipher and helping them understand that means that the child is asking for information or suffering or showing anxiety or things like that.
Great, thank you, April. And that's a wonderful segue to Lexi, who I know has spent her career working with children of all different ages, but also helping families to have those very important conversations. And Lexi, I'd love to hear your perspective on that. How do we do that?
So as I was reflecting on the case that was presented today, I thought a lot about the importance and the motivation for communication between the medical team, parents and caregivers, and the child at the center of the case. And as it's been said by Lori and April, in my experience, parents' motivation for not sharing diagnostic or prognostic information is often from a place of fear. Parents are scared and they don't know what to say. The last thing they want to do is to pass their extreme emotions onto their child. And I've heard so many parents say, this is my burden to carry for my child. And I found a little bit of literature that talked about the connection between parents' fear of their child's death and how much they're willing to disclose about their child's illness. So a lot of my work as a child life specialist is helping children understand what's happening in the hospital, what's happening in their body. And so I have to work in collaboration with parents to figure out what they're willing to share and how they want to share that information. And it's, a cliche that gets thrown around a lot, but we often say parents know best. Parents know their child best, and it's so true. Time and time again, I've been shown that they know exactly what information their children need and when they need it, even if they struggle to provide it themselves. And so I feel that our job as the medical team is to help parents work through their fears and give them confidence in sharing appropriate information with their child. Often this takes time, as parents have to build trust in our team. And after significant medical setbacks, such as a relapse, some elements of trust have to be fortified. And this is the case even for families who've had very long-standing relationships with their medical team, such as the patient in this case. Oftentimes when I've hit a wall with parents about what they're willing to disclose, I found it helpful to reframe the conversation. So I talked a lot about what you don't want to share, but when you look at your child, what can we share? What can we tell them? Or other kids and families have told me that this was really helpful to hear. Do you think that we could share something like this with your child? I think showing families that we can provide children developmentally appropriate information in a way that takes away some of the scariness or the fear is really helpful to move parents in the direction of openness and disclosure. April touched on this, but it's so important for children to have very concrete explanations even up through early adolescence. And we know that hypotheticals and unknowns that are running through parents' heads is often where a lot of fear resides, and that's not information that we need to share with an 11-year-old child. I often hear parents, especially at diagnosis, say, I have no idea how I'm going to share this with my child, and it makes total sense. They're sitting down in meetings and hearing about 5 different chemotherapy drugs, and that their child's going to surgery for a biopsy or a line placement. And, now we're telling them they have to tell their child, like, how do I even begin? And, one of my favorite go-to lines in oncology is, cancer is extra cells in your body. They take up too much space and they don't have a job. And we need to give you medicine to make the extra cells go away. It's accurate, it's honest, it's concrete, but it's not asking we're not asking parents to tell their child what's going to happen months down the road. And oftentimes when I give that example, parents sort of have this aha moment of, okay, I can do this. There are words that I can use and I can help my child understand what's happening. As far as the ethics of the line of what is acceptable to withhold and to share with families, I find myself focusing a lot on the child's symptoms and what treatment is being offered to them. I do feel that children should have the autonomy to know why they need medical intervention and generally why they're feeling certain symptoms in their body. In this case in particular, it struck me memories of multiple children who had relapsed leukemia and had flat out said that they could feel the leukemia in their body. So the thought of this multiply relapsed child not picking up on the behavioral and the emotional cues from her parents, along with the own feedback within her body, seemed to me to give pause that she would probably knows a lot more that's going on than she's discussing with her parents. And I feel that sometimes helping parents understand that their child is more aware than they're sharing is a really good jumping off point that helps parents find confidence to be more open with their child. And as Lori and April both said, at the end of this journey, the parents have to live with what was and wasn't said. And it's in the best interest of the entire medical team to respect the wishes of the family. But I feel that our moral obligation lies in the fact that we make sure that we've provided every resource, every opportunity, and every support measure to help the family make the best decisions that they can at this worst time in their life.
Thank you, Lexi. A lot of wisdom there already. Told you this was a great panel. Matt is now going to clarify that space of where families are coming from, but from their perspective of culture and religion, and what insights do you have, Matt, about how to navigate that?
I feel like I should just cede my time to Lexi and let her talk about faith. I mean, she's pretty good at this. The thing that strikes me when I think about this is 2 points. One, this question about how are we treating, what's our responsibility to treating pediatric patients and their families? Right, we do have this balance of responsibility to the whole unit. And then the other thing that's obvious for me in the case is that last line, the family refused to tell her, stating they worried she would lose her faith in God and God's plan. They wanted her to enjoy the time she had left with her family and friends without feeling sad or anxious about the end of life. So for me, if I were going to come in and speak with this family from the perspective of a chaplain, that's where I would want to scratch around and find out more from their perspective, because they've got this, whatever their religious frame is. And a lot of us know that many folks who lead with religious language and a religious framework about how they make decisions, it's not just a hobby or an activity. It's a part of their family culture. Maybe it's a part of their identity of being Muslim or Baptist or whatever it is that they are. And so I would want to approach that with as much like humility and curiosity as I could to understand more about both the family's context of their faith and how the parents frame God's plan and the faith in God, and then helping, because in a sort of a deference of respect, right? Asking them to tell me what they understand about her faith. And then if they would allow me to be able to explore with her about how she understands God. But I think that it would be an important point. I mean, just like Lexi brought up, is there's a lot of value in being able to explore with the parent, what do they understand about faith in God or God's plan, and how this may or may not fit into that. And then taking that understanding and trying to insert it or extrapolate it into what the patient might be experiencing. And some of it is this idea of being able to lend the parents a little bit of courage to engage in those conversations. Some folks, their faith is, if you ask them a follow-up question, well, what do you mean by God's plan or God's will? They may not have a lot of extra words beyond that. And that's cool. We just need to understand that. But a lot of folks have a real deep well of more understanding and how they think that this fits in. And then once we get a little bit of a groundwork on that, then we can work together on our side of the street as a team and work together with the family to say, well, we think that this might be valuable, but we understand what you're doing because in the end, as several of the people have mentioned already, like they're this child's parent and they understand her faith journey about as well as anybody other than her. They understand what it means to be her parent and what it means for her to be their child about as well as anybody does. And they're the ones, we're with them in this kind of finite, discrete time. And so we need to think about what they have lived with her up to that point and what they're going to live with afterwards. I know that for me, whenever I find myself getting worked up about, oh my goodness, what do you mean they're not going to tell her that she's not? I have to check myself and think, well, what's my motivation? What's my interest point in this of saying, oh, you've got to know. The child has to know. I have to back up and think about their particular context and then try to balance this responsibility to both the family as a whole and to the patient in particular. So I think I'll stop with that.
So Matt brings up a really important dimension of this particular kind of case, and that is, as Lori mentioned in the very beginning, that we can feel morally distressed when we feel that we're being asked to lie, to not tell the truth to a child. And as people committed to the care of children and their families, that seems like a really profound request when we value honesty and transparency with the people that we're taking care of. And Matt pointed out that sometimes that can lead us to almost a kind of self-righteous indignation that the child must know. And I think that sometimes then leads us down a path of really questioning parental authority and saying, you know, should these parents be disqualified as parent decision makers for their child because we perceive that the risk to the child and to their not knowing is so great that, and our obligation to inform the child of their situation is paramount, that we begin to look for ways to discredit the family. And sometimes that leads us to ask the question of, is not telling the child a form of neglect or abuse? And so then we look to our child protection team often, and we hear this sometimes leveraged, should we call child protective services? And so I wanted Simone to talk about that a little bit so that we can explore what the boundaries might be. And is it ever an option that we should even be thinking about in these circumstances? So Simone, can you, as someone who has dealt in this territory for a number of years, can you offer us some insight about that?
Certainly. So I'm a social worker, as Cinda said, and also the associate director of our child protection team for the hospital. And so I'm often consulted or brought in or engaged in discussion when there are concerns about parental decision making. And I can think of quite a few situations that maybe vary in the fine tune aspect or the specifics of the aspect of this case, but generally fall within the team is concerned that the parent is making the wrong choice. And it ends up actually being framed that plainly. The team knows that this child needs X, Y, and Z, and the parent is choosing to do something different. And what's interesting is that it's often framed as we want to protect the child, or we want to advocate for the child in this instance, and the parent doesn't, or the parent isn't as worried as we are, or why don't they know what this kid needs? We know what this child needs. We have to do something. And what that misses is quite a few things that have already been touched on to some degree. But that the parent or parents know this child better than we do. They have a much longer standing relationship and will continue to be in relationship with this child even once she dies, however it is you define that. But as various members of the panel have said, the parents will have to live with their decision making over time, and obviously a far different way than any member of the medical team. The other aspect is, well, there's multitudinous aspects, but I think that as medical providers who are used to having discussions around difficult diagnoses and death and dying, we as a medical team may come to a thought or preliminary medical plan relatively quickly, knowing the child's diagnosis and knowing her history. To expect parents to get there as quickly as we do is ridiculousness. Most people don't engage in conversations about death and dying, particularly in pediatric population, and certainly not about their own kids. It's the last thing that a parent would want to even consider as a possibility. And so all of the things that have been mentioned about the parents saying that they want to protect the child, they're concerned about her belief in God and her being able to live as fully as possible in the time that she has remaining, are a parent's efforts to actually protect the child. And it may take time for them to hear information from all of the specialists that have been engaged in this conversation and the doctors, and to hear the information provided, to process it, to understand it, not just intellectually, but in terms of their social emotional relationship with their child. When a team comes to me and says, but the parents are making the wrong choice, or even before they get to that, when the team comes to me and says, these are our concerns, one of my first questions will be, and what has your conversation with the parents been? What has been your engagement with them around your concerns? There's the state regulations say that if a medical provider or teacher or other mandated reporter has concerns, they are obligated to report. So then sometimes I will have a provider say to me, oh, well, but it says that I have to make a report if I'm concerned. Yes, but I think that there's latitude for fully understanding the context of the situation versus making a report as your default first step. Because the agency being Child Protective Services or whatever the child welfare organization is for the given state, will ask, what is the parent's understanding of the situation? What choice are they stating an intent to follow? And what is their reasoning behind it? The parents in this instance have laid out their concerns. They're being thoughtful about why they want to pursue a particular course. They're not coming up at this sort of like, we refuse to engage, we refuse to talk about it, we refuse to be involved in this child's medical care at all, and we don't want her to know what's happening. They're being very mindful about why they are choosing what they are. And again, I think it's hard to tell from the scenario, but it's quite possible that we're still relatively newly along this relapse path. And to say that the parents have been given opportunity to fully discuss it is perhaps not fair. Lastly, in cases like this, so the state will intervene in parents' medical decision-making if their decision acutely threatens the child's well-being. Elucidating that threat in a case like this, I think, can be very, very difficult. But typically what they use as a measure, and this is a mass generalization, but typically what is used in circuit court, if the state is seeking to be able to intervene on behalf of a child, is what is the threat? And if we're talking about mental distress or mental injury, it's that there's been profound impact on the child's ability to function and their developmental capability. I think it would be hard to argue that in this instance, besides the fact that she's also ill. It would be a conversation perhaps to have, but I think that the reality is that the state is very unlikely to intervene in families making choices for their children if they are able to say why they are making those choices and they are doing it in a good faith effort. The fact that the medical team disagrees with what they think is in the child's best interest would not be sufficient reason for a parent's choices for their child to be undermined.
So we've really had a robust conversation so far. I just wanted to reflect on a couple of things. One is how we sort of balance our commitments both to the patient, the family, and to our own integrity in a case like this. And it's the kind of case that really can provoke a kind of moral suffering on the part of the team. And so I think it's important to acknowledge that when you're confronted with a case like this, where the trade-offs ethically really result in outcomes that we perceive to be unacceptable. That's the ingredients for moral distress and moral suffering to occur. And so part of what we need to be thinking about is how do we actually create the environment where we can acknowledge that these are hard cases. There are hard choices there will be a moral residue, because no matter what we do, there will be unmet obligations that go along with that decision. And so part of it is, how do we step back from our certainty about what the right answer is to be able to create a space where it's possible for something to emerge that we may not see clearly right now, which is, I think, part of what everybody has been saying here is we need a space where we can offer support and resources to families and to the child themselves to see if it's possible to move from this either or stance to a place of and, which means creating a space where everyone at the end of the day can have a sense of integrity. So I'm wondering about, are there questions from our community about this particular case that you'd like particular panelists to respond to, and invite your engagement here.
Thanks, Cinda. We have a question first for Laurie. As a chaplain in training, I am stuck at Laurie's story about the 5-year-old. How sick am I? What did she say? Did she say something like really sick and then try to have a conversation with the parent about the question?
So at first I took a deep breath and then I said that it was a really, really good question and asked her what she thought. And she really had no idea. And the next thing was to say, that is a really good thing for us to talk about with your mom and dad, because I think that they're thinking about that too. And then I talked with the parents, and we went in and had a conversation with her, as Lexi would be proud of me, in a very concrete and developmentally appropriate way. And, we talked about the number of people, like who helped you to get better when you had strep throat? Have you been sick before? Who helped you to get better? It was just mommy and daddy and Dr. blah, blah, blah. And they said, so this time it's going to take a lot more people. And how long were you sick before? Like try to quantify different aspects of her illness. And so, yeah. So kind of like what you did, but used it as an opportunity to bring them together. It was a stressful time for all of them. So I think her parents appreciated the hand-holding in having the discussion with her.
Thank you for sharing.
Sure.
The next question we have is just generally for the panelists. Do you have any insights or opinions on how this discussion could be applied to elderly, incapacitated patients who are dying? For example, a patient with dementia whose spouse doesn't want him to know he's going to hospice. Would you approach this the same way as you would a parent-child, or is it different because the patient is an adult?
So in neurology, we do training in both pediatrics and adults. And so I've been in this situation as well, or similar situations. And it's surprising, or maybe not surprising, how similar end of life is to caring for children. As we all know, our brains and our function peaks probably earlier than we want to admit, and then some things go away. And in both extremes of life, it really comes down to what is important. What is important to the patient, whether a child or an older adult, or it really at anyone at any time of their life. What's the most important thing for them? What will they want to know, and what comforts will they want to have at the end of their life, whether they know that it's happening or not. And I think particularly with dementia, it's a similar kind of screening process or evaluation of, as you do with children in their development. What can they understand at this point? What do they focus on? What do they talk about in the times when they are verbalizing? And if they aren't able to verbalize, what signs or cues are they giving that they are uncomfortable or they don't understand or are confused? And so, you know, being able to partner with the family or the caregivers in sharing what we as providers pick up on and understand and think they understand, and helping translate that for the caregivers so that they provide the comforts that the family member would want, that the patient would want.
Just one additional thought on that. We've talked a lot in this case, kind of worked under this assumption that the child wants to know and wants to hear whatever information from somebody beyond their parent, or would be open to that. I think it's similar with adults. I mean, it's a pretty big category of patients who defer to whoever their caregiver is. I've had a lot of adolescents who say, I don't want to talk about you talk to my mom, and then she'll tell me what I need to know. Everything gets filtered through them. And it gets similar towards the other end of life, where people say, no, you've got to run it past my husband, my spouse, whatever, my sister, and then they're going to interpret it for me the way I need it. And so again, just respecting context, understanding context is the first big task, and then being able to respect it as best we can.
Thanks, Matt. So the next thing is a comment for you, and then I have a question for Laurie. So Matt, I really liked your mentioning your initial reactions to a case. As a community member of a hospital ethics committee in Baltimore, I have struggled with that and realizing that this is not the focus for ethics. For Laurie, for the child who tugged on her scrubs and asked her what is going on, did she answer? What if the parents had said they did not want staff discussing death with their child, even if the child directly asks?
So I think I kind of answered it about the first little kiddo, but I can say that we have had cases recently where you're sort of in the room and navigating between two separate universes, you know, that the parent who will have had many discussions about the end of their child's life, the child is not talking about death at all, whatever is going on in their head, whether they are thinking about it or not. You know, we recently had a young adult who was doing all kinds of life review, and like 2 days before he died, he was working on setting up his website, you know, like still thinking of a long and glorious future. And you just find the way to fit in. Like, his parents did not want anyone to say anything about dying to him, and it happened, and he died peacefully. So I don't know if that's an answer.
So I think what might be underneath some of this question is, are there any boundaries in terms of honesty here? Several people brought up the idea of if the child asks you directly, as you illustrated, Laurie, you know, am I dying, or how sick am I? How do we respond to that with integrity? And are there any boundaries that we need to create with parents about our ability to honor their requests? Are there any boundaries that we ought to have? And I'm wondering, Lexi, if you have some thoughts about, you know, how do you respond to those direct questions? Is it the case that we should say yes or no, you're dying or you're not, or is there another way to respond to that?
I think oftentimes when children are thinking about or asking more direct questions, it's, you know, why is it hard for me to breathe? Or what they're feeling, that their body is functioning differently. And I can think of a sibling who had known children from coming to clinic who had passed from cancer. She knew her brother had cancer, and she point blankly asked me, why do some kids die from cancer and others don't? And then her next question was, is my brother going to die? And it was, at that point, he had a relapse sarcoma, and but there were still treatment options. So I had not had a conversation with her mom, so paused our interaction and went and found mom and said, these are the questions that have just been asked of me. My typical reaction is, there's lots of different medicines. There's lots of different things that the doctors can try to get rid of the extra cells. And sometimes it works to get rid of the extra cells for a short amount of time. Sometimes it works to get rid of the extra cells forever. We don't know why when some kids the extra cells come back, or why they get really sick and die. And so but we know sometimes if the medicine stops working. And the little girl basically wanted me to say, will you tell me if the medicine stops working for my brother? And was able to confirm with mom that that was something she was willing to share. So brought mom back in, finished the conversation, told her yes, that right now the medicine is working. And if that changes, that we'd let her know. She spent the next year and a half asking me monthly, almost every time I saw her, remember, you told me that if the medicine stops working, you'll tell me. And it was a good segue to the eventual conversations that we did have to have, and a good reminder of a promise made by her parents when the time did come to have those conversations.
Thank you, Lexi. We have a number of questions and comments. I'm going to try and get to as many as possible. The next one is, to all panelists, how frequently do you see religious beliefs as a major factor for parents' considerations?
I'd love to hear both the folks who are clinical nurses and physicians on this. From my perspective, I know that there's a lot of research that says when you ask people how they make decisions for their children, specifically medical decisions for the children, a lot of folks say we take in all the medical information and then we do our best to understand it, and then we make our decision based on our religious perspective. That's like the primary filter that people use, and it's balancing the facts and the science that are with them, and then having, especially in situations where people are having to make these kind of gut level decisions that maybe there's not a great way forward and they're trying to do the best that they can, then they rely on their religious context and what they think fits for them from that faith background and within the context. Another thing that we haven't really talked about is the context of the communities in which people live. The individual family is going to have to live with whatever decisions they make, and they're bringing their own history, but then there's often surrounded by a faith community, a religious community that is present with them as they're making their choices. There's a comment further down on by Rabbi Shur mentioning that in Orthodox Judaism, they rely pretty heavily on their rabbis to make serious medical issues and serious medical decisions. And so I think it's a big piece. I don't know, does anybody else, Lori or April, anybody have a thought on your experience on this?
I would like to add, I think that one of the things that I see frequently is also not just the religious piece, but also their cultural piece. There are some families that do not practice any religion specifically. However, they'll say, well, I relate to being Christian or Jewish or something else. But it's really interesting to see culturally And again, another culture is the Hispanic culture. They are Hispanic and they speak Spanish, but that's not the same Spanish and Hispanic culture from Mexico to Cuba. And so really understanding where they are, do they live amongst a lot of their own culture in one place in the area, also really influences not only who they want at the bedside, who they want to participate in care, but also their decision making. And there's just so many variances that I think we need to keep that in mind.
So we have had a very robust and complex conversation about an issue that I know creates a lot of distress for everyone who's involved, the families, the children themselves, and importantly, the clinicians. And so our goal today was to engage in trying to examine this question from many perspectives and to recognize that while sometimes it might seem like there's only one answer, that there's often many answers. And part of our relationship to the uncertainty of knowing what is the best answer in this circumstance really leads us to consider all the contextual features that we've heard about today. And to know that even when we've made the best decision, all things considered, we may not feel satisfied with the choice. And that sort of moral residue is an important part of recognizing how we need to pay attention to that so that we can actually support each other integrity in these situations and not let it accumulate to a point where it's really causing harm to ourselves and ultimately to other people. So thank you so much for being part of this conversation today. And I want to thank our incredible panelists for their wisdom today. So thank you.